We'll get ourselves started here because I know we've got quite a number of panelists, and we want to be able to let everybody speak and be sure that there's time for Q&A. So I am Wayne Stewart. I am the co-director of CAPS's Intervention and Implementation Core, which is one of the components of CAPS, along with the Methods Core, that's sponsoring this, and CAPS is co-sponsoring this entire series of talks on adapting HIV and other interventions. It's being co-sponsored by the CFAR and by the UCSF Department of Epidemiology and Biostatistics Implementation Science Program and Prize Center. And this is the second of the four-part series that we were doing on adapting to the COVID era. And the focus today is going to be on ethics. And for that, we've turned to Bill Woods and Judy Tan, CAPS faculty members, who are ethics specialists within the faculty here. Bill, of course, was vice chair of an IRB committee here for many, many years, and Judy, and as he has moved towards retirement, is actually in retirement, Judy has taken over as a member of the IRB, and so they have the connections into our IRB and have invited a set of panelists from the IRB to speak to us today about the kinds of issues and challenges that they are witnessing as people adapt their studies to the COVID era. And the guests that include Jackie Tolsky, Elizabeth Mendelson, Edward Kwesinsky, Joanne McCallion, who used to be at CAPS years ago, how she and I know each other, and Sherry Etter. And I will just say, and as kind of a personal note, that over the years I have gone to Bill, particularly since he was historically our go-to person, with many an ethical question, always some sort of hideous conundrum. And the names of the people that you see here today are 99 times out of 100 the names that he said he was going to consult to get the answers. And so it's great that they've all been able to be here today, and I look forward to what everybody has to say. So Bill and Judy, I will turn it over to you.
Wonderful. So I will go first and introduce myself. I am assistant professor. My name is Judy Tan. I'm assistant professor at CAPS and current IRB committee member of the San Francisco General Hospital Committee. Bill?
Yeah, hi folks, and welcome. Thank you for joining us. My name is Bill Woods. I'm, as Wayne completely introduced me, I'm an emeritus professor at CAPS. I still do some work at CAPS and as a recall professor, and then I was a long time, it seems like a long time ago now, the vice chair of the same panel that Judy is on now, and worked very closely with Elizabeth and Jackie in that role, and obviously with Joanne and Sherry as well. So in the interest of time and making sure we have a lot of time at the end for answering the specific questions that investigators and staff have about their research and the IRB, what we decided to do was to just ask each panelist in turn to introduce themselves, to give you a little bit of a picture of who they are, and then spend about just a few minutes talking a little bit about their experience so far with handling IRB issues and investigators' response to the COVID epidemic or pandemic. So to that end, I thought what we'd do is just start with Ed Kwesinsky, the IRB director. And Ed, do you want to go ahead and take it from there?
Thank you. Thank you, Bill, Judy, for organizing this and inviting us all to participate. As Bill said, I am the director of our Human Research Protection Program. I'm new in the role since about May, so I actually sort of dropped in on you all shortly after you had gone through the shutdown exercise and then a gradual sort of restarting or a sort of a reconfiguration of research protocols that were already in place and new ones that were coming in specifically to address the COVID pandemic from your various research perspectives. I'll just say a couple of things about what I have sort of observed as first as a brand new sort of entrant into the into the UCSF community attempting to deal with this. And then secondly, as someone who's learned a little bit more and become involved in helping to either to design or evaluate suggestions for altering research protocols so that they can continue in a safe and ethical manner. So the first thing that I would observe from the regulatory perspective is that prior to my arrival, the university had issued guidance. The HRPP had issued guidance that, look, you don't need to be, you as investigators don't need to be coming to the IRB with requests for approval of modifications that are going to keep your research participants and your staff safe. Make the changes that you need to make. And you don't need to tell us about them in a modification. You don't need to go through the paperwork. Just keep everybody safe. Figure out what you need to do. There were recommendations and suggestions to do such things as convert in-person visits to remote visits whenever possible. Eliminate visits that weren't absolutely necessary to the successful continuation of the research. Figure out ways to maintain social distance and mask if contact was going to be necessary. Things of that nature. And those guidelines are still in place, actually. Now, of course, most of the studies that have been underway that involve recruiting human participants have gone through or are going through sort of a renewal process, continuing review, or other modifications. And so at that point is when we'll want to hear about the kinds of modifications that study teams have made in order to make it possible to continue. And among some of those sort of modifications, we've encountered proposals to send third-party, say, home healthcare agencies out to conduct visits in a participant's home, and that has come with a series of sort of questions from the IRB about the protection of privacy and the safety of the participants being visited by an entity we don't have any direct control over, for instance, in terms of what kind of training, what kind of safety precautions do they have in place. We have had study teams configure or come up with suggestions for setting up, in essence, a tent or some sort of outside environment so that the visits, the social and behavioral study visits could be continued without the need to bring individuals onto campus and into indoor space. Of course, that was complicated by the fires recently, but that seems to have diminished. And so now that's becoming more of a viable strategy, especially given current air quality and the weather in general being conducive to things like that. From the ethical perspective, I think one of the aspects of doing research out in the community that has really struck me has been the absolute necessity and the value in engaging with the community via the community advisory boards that UCSF has established through its stakeholder and community engagement program in the Ctsi, and other opportunities for gaining the trust and the buy-in of the community representatives for conducting research out in the community. And it has caused us to consider such issues associated with, say, visiting COVID-19 infected or possibly infected research participant at their homes, associated with, and the degree to which the unit, the household unit, has access to appropriate PPE and information about how to disinfect and things of that nature. So we've been assembling people to discuss these kinds of issues. I would say that in contrast to perhaps the historical tension between underserved communities and big research institutions that attempt to recruit from among their members, like UCSF, other UC campuses. In this instance, there's general complete buy-in and support for the kind of research that we're attempting to do to understand the impact of COVID-19 on the communities that we serve. And so that's made it easier to sort of partner up with community advocacy groups and other sort of NGOs that might be serving the various communities to help together come up with, you know, reasonable research protocols that can be supported and actually will be able to recruit. So I'll stop there and turn it over to one of my colleagues, whichever is next.
Right, I think we're going to go with Joanne next. We want to make sure that Joanne and Sherry have enough time to speak to us. I think most of the CAPS investigators will be doing a lot of exempt and expedited studies. So your input will be very helpful. Thank you.
Yeah, so I'll give you an introduction like we talked about before. At the end, we're welcome for questions. And if we can't sort it out here, definitely email us and keep in touch with us. So I'm one of the 2 IRB managers in the office. Our other manager is Jason Keenan, who's on here, and he works with full committee. I'm the manager for minimal risk research, which includes expedited and exempt review. And we also, in the minimal risk team, we make the not human subjects research determinations. So that's for things like clinical QI and public health surveillance. So I've been at the IRB for about 16 years after many years as a project director for large multi-site clinical trials at the VA and at CAPS, like Bill was saying. And so I was thinking about the challenges for the IRBs at the beginning of the pandemic. And one of the challenges at the beginning, and still a challenge now, is how do we manage this large volume of new studies that need review as soon as possible? So in February, I was working on a couple of lab-based studies for SARS-CoV-2, and people were all in a panic and we've got to get moving. And I looped in Sherry Eder for her expertise in lab sciences. At that time, our senior vice associate for research said to me, we need to have a way to respond to a PI in 3 hours. And I said, okay, I guess they could email me and I'll respond to them in 3 hours. So that decision led to what you saw on our website, where we were asking people to email us when they turned in a new study, or to call us and talk to us if they needed help designing a new study. And that's a little different than the AOTD method, right? You call us with an analyst of the day question, whoever's on duty takes it. What was a little different is we just dedicated 2 people who that's all we did. We kept it very focused. And I think that the positives of doing that was people needed to get up and running really quickly. We'd have people on, I've got the sponsor on one phone, I've got the chancellor on the other, and I've got Joanne and Sherry in a Zoom waiting to set all of this in motion. And it was good, another reason it was good to have 2 dedicated people was there was a lot of crossover. You guys don't have as much crossover, but in some of the biomedical, everybody knows each other and somebody's co-PI on somebody's other study, and we could just put that all together. So our analysts are working hard. They're managing all of the COVID as well as the regular research. We're not getting behind. They're superhumans in our office, and we're grateful for all of the hard work that they're doing. This method also helped us with, there was a lot of changing in the FDA regulations. There wasn't a lot of what you see now with the FDA regulations. And when they started making changes, they would change daily, if not hourly. And so you might see some studies that were given different determinations in March or April than they're given now. Not a problem, it was just an evolution of the guidance. So that was one of the challenges that a lot of IRBs had, was how do we deal with this volume? And we did it by having a small dedicated team. And we still do ask that if you're going to do one of these projects, email us, write to us, and we'll help you with the process. The other new piece for us was public health surveillance. We weren't seeing a whole lot of public health surveillance, and suddenly there was a whole lot of it, and there's new guidance about it. So those early researchers really helped us practice through that process. And we're happy to talk about public health surveillance projects if you guys want to bring that up in the Q&A. So these are projects that are designed by a public health department. They're not designed to contribute to generalizable research. And I know that's a fine line and it doesn't always make a lot of sense. So that's why you call us and we'll talk it through. But if you know what public health surveillance is, you know it doesn't need IRB approval. It doesn't need an IRB approved consent form. That being said, we are asking at UCSF that you turn those in. And so I wanted to do a pitch for this while I have the opportunity. If you're going to do one, turn it into us, call us up, we'll help you write it up. Why do we want to do that? Number one, we want to sort out if there is a research component. Some people do a public health surveillance project and they tack on a survey or they tack on their own research. So we need to sort that out. Secondly, it might need a device determination, as wacky as that sounds, and we'll work that out with you and do an FDA consult. And thirdly, the university is keeping track of the number of surveillance projects that we're involved in for local and state reporting. And the only way to do that is to turn in an application for us to tally up the numbers. And with that, I'm going to turn it over to Sherry Etter.
Thanks, Joanne. So I'm Sherry Etter, and I am one of the IRB analysts. I review risk research, exempt and expedited mainly, and I also coordinate the UCSF Stem Cell Research Committee, also known as GESCR. And as Joanne explained, we've kind of been on the front lines of responding to all COVID-related questions, or a majority of them, since March. So it's been a fast evolving process. I want to just touch briefly, since Joanne and Ed kind of gave an overview of the things we've been, thinking about and dealing with, just about some of the practical things of ways researchers have been dealing with all the new guidelines brought on by COVID-19. So the Office of Research is actually, in addition to the IRB COVID FAQs, the Office of Research also has a lot of information about suggestions. And I honestly hadn't read through the entire thing until yesterday. And I was really amazed at all the suggestions that are out there for researchers. So, and I think the underlying message in most of the suggestions is, if you can do something remotely, do it remotely right now. I think that's just for recruitment, consent, and procedures. Anything you can do to minimize contact with subjects in a study is preferred to reduce the potential for COVID-19 transmission. So, we think about recruitment, emailing, mailing, calling, recruitment, ad posting, having people respond. We also have a great service, CSF, the Ctsi, participant recruitment program, that a lot of researchers have been using and discovering since the onset of the pandemic. We think about consent. Can you do online, consent, implied consent? Can you do verbal consent via phone, Zoom? Can you get signed consent via DocuSign? All of these things that you can do to reduce contact is great. Some of the procedures, we've seen a lot of telehealth. If you're doing clinic visits, virtual study visits by Zoom, phone surveying, interviewing, a lot of people using mobile technologies. If you're paying people, e-gift cards. We've even seen, medication distribution starting to happen by mail. So that's kind of, I don't see a lot of the full committee studies these days, but I just saw one like that. So I thought that was really interesting. So if you do need to do an in-person visit and it can't be avoided for whatever the reason, of course, the Office of Research has limitations on, if it's not a study that has direct benefit, they have limitations on how many participants or people can be on site at any time for the study. But just tell the IRB why it's necessary. Provide your risk mitigation plan. So I see a lot of minimal risk studies that don't really go into the details of, what are we going to do when we have contact to mitigate risks? What kind of PPE, what kind of distancing, disinfecting? A lot of times people are handed, laptops or iPads to do a survey. What in between participants, talk about disinfecting. Can you meet outdoors? Like Ed said, that's come up. Make sure you're doing the health screening, ahead of time before you meet somebody in person. So things like that. If you're offsite, of course, you would have to follow the guidance and the policies of whatever location you're going. If you're in San Francisco, of course, you have to follow SFDPH criteria. And like Ed said, you can seek input from community informants, community advisory groups, community stakeholders, depending on your population, and talk about all that in your IRB application. I saw a few studies recently with sample collection and some kind of unique ideas to, if you can, mail kits. People have set up Zoom, nurse conference or study staff conference to help people collect samples at home, to walk them through the procedures, or providing instructional sheets. I saw one recently where they wanted to do a blood spot at home. So they mailed a kit, the nurse would call them, they would go through the procedure, and then somebody from the study team would come and pick it up. But they didn't discuss, how that was happening. And so basically the participant's going to leave it, in a bag outside, on their door or whatever, and somebody's going to come by and pick it up. So there's a lot of kind of unique things happening in studies. And of course, if you're doing something in clinic, talk about your risk mitigation strategy. We're going to protect the staff and the participants from COVID transmission. So that's kind of a 360 view of some of the things we see. I'm sure there's lots more that I couldn't even think of, and we're happy to talk about any or answer any questions you might have about how to do a specific procedure, or any ideas or thoughts we've seen, in studies that have come in. So that's my overview, and I guess I will turn it over to Jackie Telsky.
Thanks. Actually, I'm really, really happy to be invited to this. I'm an old CAPS touched by Margaret Chesney person. So this is like coming home to be talking with you all. I'm an internist and addiction medicine specialist, HIV specialist by training. And I'm the vice chair on the committee that Bill abandoned, but he didn't abandon us in a bad way because he gave us Judy Tan. So I work with Elizabeth Mendelson on this full committee, and then I do some the expediteds where they're asking for faculty review. I think my colleagues touched on a lot of the major points. I think for the question and answer period, some of the things that I may be able to help address is, you at CAPS have been well aware for a very long time, the investigators, of thinking about both the physical safety and psychological safety of participants and staff. And so in some ways, the COVID challenge, the COVID pandemic, doesn't have to make you think about a whole new area. It's just the psychological and physical safety weren't necessarily around an airborne contagious disease. So you're very comfortable with when you were doing blood studies, knowing how to draw blood safely and transport it safely, but and in focus groups and support groups where someone may have a real psychological distress, CAPS study applications were often the models for how to de-escalate and address a crisis, mental health crises or emotional crises. So you all know how to do that in spades. It's just, and then adding on both thinking about stigma issues related to COVID that may not be apparent right on the surface, and obviously are different than the stigma of HIV, but clearly exist. And then I think the physical safety sides that I think of on the medicine side are not being lax with respect to staff, both staff safety and staff as a vector for COVID transmission. And at this point, we've answered so many screening questions going into buildings and going into clinics and going into our own physicians' offices or NP offices that you get quite almost immune to really thinking through, is my sore throat a sore throat that I need to mention? So, part of what I would want to say is in your study design, part of the ethics is that you really refresh and encourage staff to be as thoughtful about their own health and not being at all someone that would be bringing COVID into an interaction. And then the last thing I would want to say, just as a something that again I can maybe help field questions, is that while remote makes it feel very safe from a COVID point of view, part of what and I think Sherry and Joanne both brought this up, and it'll come up when Elizabeth makes comments, that remote doesn't guarantee the privacy protections, or again the sort of stigma safety protections that if a person lives with a group of other people and then you're asking them to answer questions about sexual practices or health practices, that may well put them in a privacy bind that you want to think about in your design and in your mitigation strategy. So it's not directly COVID, but it's indirectly because of COVID. I think I'll stop there. And then Elizabeth, who is my go-to person on the full committee. So I'm really happy that you're joining us.
So everybody thinks of the full committee studies as greater than minimal risk. But if you think back to the beginning of the AIDS epidemic, it was in the beginning, those were not low risk behavioral studies. There were a lot of really sensitive questions in a very vulnerable population. And thus we have, it was Steve Morin, then it was Bill, and now it's Judy serving on that committee. And a lot of SFGH is no stranger to behavioral studies. A lot of CAP studies will cross over and have to come to the full committee where we might make that determination that they are minimal risk. But in the beginning, we're going to want to look at them and think about randomizing studies when you have two treatment groups. So I know some of you do have studies that come to this committee. And but with COVID, there's a lot of the practices that you can use for a minimal risk study aren't going to work for a full committee. Or some of these behavioral studies. Let's take, for example, a study where you're dealing with parents and their children, and the way you had it set up initially, you could separate parent and child into different rooms and talk about it. Now, if you're going to do it on Zoom, that's not going to work. So when you switch from a focus group to individual, you have to switch to individual interviews, and that takes a lot more research staff, a lot more coordination in figuring out how to plan this all out. So there's a lot of logistics that are involved with that. If you're thinking about switching a study, your method of informed consent, you can't do verbal consent or implied consent when it's a greater than minimal risk study. So they have, and then if you think about adding surrogates to it, there are studies, greater than minimal risk studies, that have had to shut down completely while we rethink the process of especially if you're talking about an emergency medicine study where time is of the essence and you need to do it within the first few hours, and there's no family showing up at the hospitals. So that's been really tricky to figure out. And in the meantime, while all this is going on, there's other studies that are still happening, like malaria. Malaria never goes away. There's always a bunch of malaria studies. There are a lot of greater than minimal risk studies for treatments that still need to continue. And then how do you do it? How do you do it when you have a family member that you have to give a drug to that would compromise their immune system, and now the whole family has to go into shutdown for 14 days? And think about that. If you've got brothers and sisters who are particularly, let's say, adolescents who never follow any rules, the whole family has to shut down. So thinking about how you're going to mastermind all of that. And while we had all these studies come through, you have to figure out on the spot, what's the best way to do this? What's the language that you put in those consent forms to let people know all of the studies that we're doing with the Latinx community? Then you have to figure out, like, that affects not only them, it affects their families, it affects all the people that they work with that might also have to be isolating themselves in a situation where that's not possible. So there are all those things that you have to figure out on the fly because there isn't a precedent that's set up for it. So those are considerations that we've had to think through for all of this. And a lot of these studies are just now starting. I have studies that are just now starting to start up again. But the bottom line of things that are great to think about is when AIDS was an epidemic, we really did rethink a lot of the ways that we do research. We're doing that now. Kudos to the VA, whoever thought to do telemedicine appointments, because vets are all over the place and not necessarily near a nearby VA hospital. So every time something like this happens, it's a really good opportunity to start thinking about what's a different way that we can do research that works. The committees themselves had to start doing Zoom instead of physically meeting, and we were able to transition that over seamlessly, and we were able to keep up with still reviewing all those other studies that had nothing to do with COVID. So, you know, the plus side of all of this is it's an opportunity to rethink how we do our work and how we adapt to it. And a lot of these changes are going to go on. They're not going to end with COVID. They're going to keep changing the way we do things for the future. So there you have it in a nutshell.
Great. Thank you so much, Elizabeth. And thank you to all the panelists for your great insights and sharing with us your already vast experience with dealing with this, with the major changes that resulted from COVID, not only in doing COVID research, but also in many of your examples, the other studies that were affected by the pandemic. So, and also big thanks to all of you for speaking quickly and getting it, getting so much in there in just the first 30 minutes. So we're ready now to open for full discussion, and hope everybody has their questions and things that need to be further discussed. The way we want to try to work this is, because there's so many on the call, I don't actually see a number, but I know there was a good number of people who registered. So what we wanted to do was to ask if you have a question, and people are starting to talk over one another. What we're just going to do is ask that you chat Judy Tan, and just tell her you want to ask a question. In the meantime, if you have one now, and I don't hear people jumping in yet, so you can go ahead and ask a question. Does anyone want to start, or should
I already chatted Judy Tan several times.
Okay, great. So Wayne, why don't you go ahead and get us started?
So there's several things about CAPS and the kind of research we do here, and then the other folks that are part of this, but particularly thinking about the kind of portfolio of research of CAPS that comes up here and produces some particular issues. And the kind of overarching dynamic that was motivating some of the questions I had was the fact that we are actually, as investigators, can be quite distant from the research. Not in the sense of being uninvolved, but I mean physically distant from it. It's not taking place here in San Francisco. It's taking place like halfway around the world. And so one of the things that has already come up on some of the projects I'm involved with is how you negotiate, or you sort of work your way through the different standards that are being applied in different countries. Like there are studies that I'm on where the subcontracting agency is using either a much more restrictive standard around COVID prevention, or in some cases a much less restrictive, like bringing employees back into the office when UCSF would never do that. And how you think that through. Is it you defer to the standard of the country, you take the more restrictive standard, it's some balance between the two? It's really just not entirely clear what's the best way for an investigator to think it through, and keeping in mind that in a lot of cases these are subcontractors, so they're not technically UCSF employees, they're employees of another entity, but we're the PIs of the studies that are running the research they're on.
I have thoughts, but I think Jackie should answer this one.
Well, or we can make it a group thing.
Yeah.
I mean, I think we have had the experience with CAPS studies on an international basis where the big focus was on safety of LGBTQ staff members, and how do we deal with that in countries where that was illegal or unacceptable, or would put the person at great safety risks. And the truth is, my sense is there's a slightly different standard that we use for UCSF primary employees who are going over to these remote locations. Wayne, I assume you're mostly talking about international when you say remote. Yeah.
Yeah, I mean, this question was motivated by that because you know, we're not able to travel at this point, thanks to Donald racking up the world's highest rates of infection. So, so it keeps us all grounded here. So the question of UCSF employees in the foreign environment has sort of fallen away. And now you just have the issue of these employees that are overseas, but the standards that are being used are just very, very different than we're applying.
So Wayne, these are people who are paid by the in-country PIs or collaborators, not by UCSF. There's no UCSF affiliation.
But it's it's probably worth exploring.
Totally
and it's worth exploring what will happen when we are allowed to travel again as well.
So I would say if we got that at the full committee to look at and discuss, we would say that the UCSF employees need to be thinking much closer to the grounds of the UCSF guidelines, especially with respect to coming back in country. Certain states have restrictions on how long you can quarantine after you've been out of country. So I think for your UCSF staff and investigators, you're thinking more about the UCSF California guidelines. For in-country, my sense of it from the ones we've seen is that we ask if the NGO or the Ministry of Health or the organization has guidelines, and we ask about what those are to keep both the investigating and research staff safe. And again, this idea of vectors, where we've had people going into the villages from an urban area going into the villages. You don't want the staff to be guilty of bringing COVID into a place that it's not. And I've been surprised, but although, as you say, the guidelines are different, we haven't had any site that we've seen so far that has no guidelines on it. And often if we ask for thoughtfulness about the safety issues, they're more than happy. We've seen them upgrade some of the malaria studies, which wouldn't be CAPS per se, but where they've responded by upgrading screening of the staff before they go into the field each day, and access to masking. So at least, Joanne, that's what I would say is that, you know, when in country, we honor the in-country's guidelines, but we often ask if they have them. For UCSF, we'll probably ask for a closer monitoring. That would mean that our staff would not run across the guidelines from UCSF and California.
Well, also the prevalence in some of these countries of COVID is significantly less than what it is here. So they are able to, like South Africa didn't get hit by COVID till pretty late on. So it's always going to be an issue, but it's not as big an issue in some places as it is in others. And their IRB is going to dictate some of that. Some of the foreign IRBs are really very sophisticated, and I think we can trust that they know what they're doing.
I believe Steve Gregorich has a question.
Thanks, Judy, and thanks to the panelists. This is great. In the context of a study that requires an in-person visit that's fairly high risk for COVID transmission, say an oral health exam, the investigator could, submit an application to the IRB that it has a good protocol for infection control following CDC or UCSF clinical or SF DPH guidelines. But in the context of COVID, is the IRB looking for more data about community buy-in, say participant willingness to participate in an oral health exam as part of a research study? And if is IRB looking for more of that kind of information in the application than pre-COVID? Mm-hmm. And if they are, what types of information would fit the bill for that?
Well, I think my first question is, why do you need to do this? If it's not COVID related, we should really think about that. Not for direct benefit to the person, because that is a high risk situation. Mm-hmm. We want to think about that. Then there's also the resources that we talked about, so that I'm blanking right now, Sherry will remember. There are resources at UCSF to find out what UCSF is allowing us to do right now in terms of having that close contact with people, in terms of PPE. We want to know a little bit more about the design and why you're doing what you're doing. If Jackie might have some thoughts.
Yeah, I would just say if it's not aerosolized producing procedure, if it's an oral, I mean, in HIV, there's often important reasons to understand oral health, both for like nutrition and disease staging. So I think, Steve, it's probably not any harder to justify it necessarily than what you justified to get funding to do it in the first place. And I mean, there's pretty straightforward clinical guidelines on masking, shielding, gloving, the things for both the investigator or the clinician, as well as the what's allowed on the screening for the staff. So I think what Joanne's thinking about is right. If it's something where you're going to be, you know, having them cough or do sputums or do something that's going to produce an aerosolized producing procedure, ARP, AEP, that's one thing, and then you'd really want to have your medical staff justifying it. But I think if it's for a simple exam, dental studies or oral health studies, mostly we are probably looking at the clinical guidelines that the clinic itself would have in place if you were doing this in a kind of clinical setting of any kind.
Steve, just to address your question about community involvement, yes, we are looking more for evidence that there's been appropriate consultation and buy-in when seeking to recruit from vulnerable community populations, A, and B, although it's not in place currently, there is at the Office of Research level an initiative that is likely to request that the IRB make an inquiry regarding the extent of collaboration with something notification to the study teams, as well as to representatives from the community and stakeholder engagement program at the Ctsi, and encouraging those to connect up. And I think initially it'll be encouragement rather than requirement, but it's something that you know, many of the representatives of communities out there have been lobbying for, you know, quite vocally these days. So yes, we're very interested in promoting the notion of engagement with the community prior to launching the study.
Thank you.
Bill?
Okay. Yeah, I was just going to throw out another question about what are you seeing in terms of people starting back up? Are folks coming to the IRB? Should they come to the IRB in any way, shape, or form other than any modifications that are needed that are not the exceptions? Or what kinds of things should our investigators be doing?
What are you thinking of? Adding on some COVID component, or what are you thinking of?
Oh no, I was just thinking in terms of like some of the studies that had to stop because they were doing in person, and now they, you know, kind of are probably past the point where they should be starting back up, and not sure perhaps, or would benefit from some instruction from the IRB about like what you're thinking and what your concerns are for folks getting started, especially since they still can't do in person. They have to make
Well, there's FAQs on our website. There are things that, you know, you might think about doing, especially if it's a minimal risk study. Let's not get a signed consent form. Let's do verbal consent because it's minimal risk. Like Sherry was saying, let's think about doing our interviews by Zoom rather than in person, those types of things. And some of that requires modifications and some doesn't. And all that's on our website, or you can consult with us.
Is that easy to find on the website? I mean,
it should be.
Okay. Well, you know, some of us are older and we don't.
Well, no, but I think somebody made it smarter for us who can't.
Oh, good. Okay, great.
There's a link on the front page.
Open up our IRB. Yeah, if you open up our website, it's right there. COVID is right there, smack in the middle, and then it's a long list. You might have to go down a long list, but it has all the references. You might have to look a little hard to find it.
There's a lot of information on our website, and there is also at the Office of Research website, there's guidance surrounding all of the practical logistics associated with what level of PPE protection do you need for what kind of a visit. And I want to just emphasize the fact that there's no absolute prohibition on conducting in-person visits.
Right.
The study teams simply need to very carefully evaluate how they're going to conduct them safely. And that all has to be written down and has to follow university guidelines, and it's going to have to pass muster with whatever IRB panel takes a look at it in terms of adequate protections and engagement with the community.
Mm-hmm. Yeah, Ed brings up a good point, because sometimes we see things where the subjects are folks who can't do a Zoom interview. They can't use DocuSign. So like Ed said, just really give us the details, just like you would any other time, a lot of justification, background for what you're doing, why you're doing it, and maybe who you consulted with on your safety protocols. Jackie?
I was just gonna say, but I would be very mindful that we are also seeing an uptick in activity of COVID in the Bay Area, like the rest of the country. And so I think you want to be very thoughtful if you are thinking you're ready to move back into one-on-one or in-person activities, because we may have to step back a little bit. Hopefully we're not going to go to a major shutdown again, but I just would keep in mind that right now we are in an upsurge, not a down cycle, and it may affect things. And then can I just ask for the audience, so if you stop the study, we stopped for safety, like Ed was saying, you just stop, and now I'm ready to, so that was a violation of my protocol, because in a way I intended to keep having people come in, do their testing, do their surveys. Now that I'm starting back up, do I need to turn in a protocol violation? Can I just ask you guys that? No. Okay, good. Because I think people are wondering if it constituted a violation to stop suddenly because of COVID.
No, we were all shaking our head no for people who weren't looking.
Yeah. Oh, that's good. That's right. People are not on video. So yeah, the answer is
people
no.
might be doing something else.
Yeah. Good point.
I believe that is in the FAQs too. On our
I'm sure it is. But
that's
you know,
right.
it's
spelled out there in the FAQs is true. But you know, if a study's been paused for months and the study team and the investigators considering restarting, it's a good idea to submit a modification. You'll have had to make many changes, and we'll want to take a look at them, and we'll want to partner with you and help provide advice if you haven't had the benefit of interacting with all of the other studies that have already figured out ways to restart safely. So we're starting to develop some experience with the scope of variable approaches to restarting studies, and we can share that with your study teams and your investigators if you go through the process of submitting a modification and letting us know what you're planning to do now that's different now that you're restarting.
I have a question while everyone takes to give a feedback on the poll there. I do have a question about vulnerable populations and how bringing research to a remote context. So typically, when we do, in-person interviews, we know the lay of the land really well. We know the community, the aid service organizations, the clinics, the resources here in the Bay Area. But once we start to expand our research online and recruit and and interview or talk to potential participants beyond the Bay Area and communities that we're less familiar with in terms of resources, what are some suggestions that you have for approaching that kind of research, given that there's just such a high need, and in my own research, heavy disruptions with people accessing healthcare in other regions, outside of the Bay Area. So in the event of suicidality or distress. You know, the remote nature of Zoom research via Zoom really prevents kind of that in-person contact. And so I'm just wondering if there are any thoughts about how you might, you know, what you might advise us to consider in doing that.
We just reviewed a study recently where it's not taking place. It's a COVID study. It's not taking place here in San Francisco, and they did, back to an earlier question, they did partner up with groups in those other counties that worked with that population, so that you could get the advice from them, so that there was some access to them. The suicidality one that's a tough one.
Yeah, Judy, I from what I was thinking as you were speaking is that, you know, if a study team is intending to conduct a study in a remote area where there's lack of familiarity with local on the ground circumstances, I would say get familiar with what's going on in that environment and partner up with some local, you know, reliable entity. Collaborate with you know, community representatives who can help describe what's going on, what the needs are, what the risks are as you design your study. I mean, that to me seems like the most important step to take.
I mean, I could imagine it could be difficult if it's like almost a web-based recruitment and you may be having people offering to participate from all over the country. It may be hard. I know it, like what you're saying, Ed and Elizabeth, we had specific counties looking at a Latinx population, and so they really were able to identify in 3 or 4 counties. You know, I do think the use of both the national hotline numbers and there are a number of national COVID strengthened hotlines around domestic violence, around mental health, suicidality. I think the CDC website has resources listed that can be used remotely for you know, people to call into. So those would be some suggestions to be able to if you have people scattered all over the country and it's not possible to have your local partnerships, that would be one consideration potentially.
Is this, you know, Judy and I were chatting about this a little. I was aware this question was coming. And I have to say, by happenstance yesterday in the class I was teaching, we covered ethics. And, you know, one of the things we teach qualitative interviewing. And so one of the things we cover is the client in distress and what you're supposed to do when that happens. And I mean, frankly, I felt like a babbling idiot when it came to like, what are you supposed to do for the client that is extremely upset, suicidal, things like that? And traditionally, in an in-person setting, there's very much the kind of warm handoff quality to it. You're there for the person, you take them, you connect them to a resource. And here it's, well, let me support you in this really warm Zoom environment that we're in. And maybe nowhere physically near the person to even be able to offer support. And then you've got all the COVID considerations that you'd have to keep in mind if you were going to try to get to the person and be there. So are there a set of recommendations? I do feel slightly better that Elizabeth Mendelsohn, no less than Elizabeth Mendelsohn, said, oh, that's a tough one. So I feel less like a babbling idiot after my performance yesterday in class, knowing that there isn't necessarily an easy answer. But are there good recommendations for that? I'm not sure what we would do.
I mean, I'm not sure there's things in writing, but as a clinician, when we've had people, I'm thinking about VA colleagues where, again, they may be talking to somebody very far tip Northern California. You can call 911 and ask for a safety assessment in the county, no matter where you are. I mean, it wouldn't be 911 wouldn't go to your county, although surprisingly, 911 can sometimes connect you outside of your county. At least I've had that experience with San Francisco call. They contacted San Mateo and sending someone. Often those are studies where you have some kind of a clinical backup person, either as a clinical psychologist who feels really comfortable with calling in for a safety wellness check assessment. So that would be the kind of thing I would be thinking about. We know that's nationwide, that there's access. Not necessarily the access you want for a client in distress where the police are sent over, but sometimes that's the option. But you know, it's a good point. I don't think all that stuff's written out in the context of COVID. Nothing that I've seen in writing.
Oh, Wayne, I guess I'd ask you and any of your colleagues on this call, what you would think might be an appropriate way to organize to respond to those kinds of interview situations, remote interview situations where clearly the participant is at some risk of self-harm. What would you think would be the right steps to be taking?
So I have an answer, but let me just ask, I've talked a lot. So is there anybody else who wants to weigh in?
And you're seeing the point behind Ed's question, right? That we put it back on you guys as the experts to come to us and tell us what you think. And then we run it by the other experts like Jackie and Judy and people on the committees, and everyone puts their heads together. But just like with all other studies and all other issues, we look to you guys as the experts. Some people call us up and ask us, what are my reporting requirements?
Yeah.
I don't know, you should know them.
Well,
I would just very quickly, you know, if we learn of best practices out there in this area or any other area, we will definitely post it and communicate it. But you know, we would look to folks like you who are actually boots on the ground in the field to come up with some recommendations that we could banter about and sort of settle on, and then we would post them and disseminate them.
Yeah.
You know, I do have a suggestion, given that we're a large university with all these different departments. Psychiatry, psychiatrists and psychologists they're doing appointments with their patients through Zoom. So this is an issue that could come up. Another department that is going to run into similar things is neurology. So it would be a great opportunity to talk to either one of those departments and see what kind of best practices they've established, because surely they've thought of this.
Well, my primary instruction to my interviewers for my own research, because this does come up, whether or not we're in a pandemic, is that we are not counselors. We are not therapists. We are not healthcare providers. We're researchers. So getting that clear, you know, so understanding where, you know, that we are wanting to obviously do the best thing that we can possibly, including, you know, handoffs, including offering resources, including, you know, lending an ear, but let's be clear our role as researchers and not in any way, shape, or form, you know, being able to provide any medical assistance.
And Judy brings up a good point. Depending on your study design, sometimes the reviewers will ask, could you put a psychiatrist or a psychologist on this study for that purpose? Or it might be a situation where the study team is savvy enough and the members feel confident the team can make the referral without having someone on their team. So it depends on the type of work you're doing, as we'll ask you to do with the composition of your key personnel.
And I'll just say, I know we got to wrap up here in a moment, but I'll just say that I mean, the way I thought through this question, the one that was asked, is you know, there's certain things that you can do in a Zoom environment and certain things you can't do. So you can still do all the assessment of, right, the stopping and making sure the client's okay. You know, do they have a plan? Like how much risk is there in the moment, the kind of stuff you would normally do if you were face to face. That part of it can still happen. My sense is that you sort of have to acknowledge to the client the limitations of the situation, that you're not there in person, and offer the support you can offer. So, I mean, you know, I hadn't thought about the call 911 and get the assessment from them, but I think that's a great strategy if it's available, namely the person's here in the US. I would also think you can offer to do things like look up the resources. So there may be a degree to which you can research the resources that you could try to help direct them to. I, for example, have a Google Voice number that I could always give out to a client so that there was a way they could connect to me or something like that, but not be giving a personal number. So, I mean, there's ways I feel like I could make that handoff as warm as possible, despite the fact that it still would be really remote.
Excellent. See, you got thinking good things. I want to just throw in, because I know we have to end, but I'm going to put in a pitch that if there are more questions like this or any COVID related questions, write to me and Sherry Eder, put both of us in the subject line. We'll write back to you. We'll pass questions on to whoever they need to go to. But yeah, keep talking with us, write to us.
Okay, well, a huge thanks to all of you for joining us, and especially to our panelists from the IRB who have done a great job in answering a lot of questions and getting our heads wrapped around what we are up to and what we should be doing. So thank you all very, very much. Appreciate it, and all the best.
Thank you, everyone.
Thank you.
Bye.
Bye-bye,
Bye.
folks.
Thank you.